Are you struggling with the SCA? Maybe you're running out of time. You don't know how to structure your consultation. My name is Dr. Erwin Kwun. I have hundreds of GP principles SCA with confidence. In this video, I'm going to show you exactly how to structure your consultation. This is part of a masterclass that I run for members of Consultation Blueprint. I hope you enjoy it. Close your eyes for a second. Imagine you're in your SCA exam. The timer on the screen says 12 minutes. You take a deep breath, and the patient appears 45-year-old woman with headache. So you start well, you greet her, confirm the name and age, and you begin exploring her symptoms. You're thinking, I've got this. Then she drops, I've been under a lot of stress, doctor. My mom's been unwell. I'm getting these headaches almost every day. You nod empathetically, you explore stress, but inside, a voice whispers, should I ask symptoms? Should I ask about the psychological problem? Or do I need to ask red flags now or later? You start jumping from stress, caffeine, sleep, and visual, like you're playing ping pong. And before you know it, you look up on the screen, 4 minutes left. And you haven't even elicited the patient's eyes, you haven't reached shared understanding, and you haven't made a plan. So the patient's eyes are searching yours, you rush. It sounds like you've got tension headache, maybe related to stress. You start talking about painkillers, stress management, CBT. Then the patient interrupts you. So, do I need a scan, doctor? And that's when it hits you. You forgot to readdress the patient's eyes, the expectation. So, you gather the data, but you are not organizing your thought process, and you fail at station because not because you didn't know enough, but you didn't have a structure. So structure is a difference between surviving a consultation and leading one with calm, confidence, and clarity. A good structure is going to actually carry you forward even when you don't know much about the problem, because you're organized and you're able to progress the consultation without missing key parts. But if you don't have that backbone, that structure, that's when you find yourself in this situation where you're rushing the management. So today we're going to talk about how you actually consult within 12 minutes. We're going to analyze the problems in your time management. We're going to deconstruct the consultation, and you're going to learn how to negotiate. And there'll be a chance to ask questions at the end as well. All right. So I hope you're excited for this evening, and we've got quite a lot to cover. So I know time management is one of the big issues. So share in the chat, what's your biggest problem with time management?
I think for me, it's over explaining.
So over explanation is a common problem. That's classic. What's the reason you tend to over explain?
I think for me, I kind of think too much. I kind of think maybe my explanations are not direct enough for the patient to understand. So I kind of like want to go over it again.
Right. Okay. So that's good that you've analyzed your consultation, found out that over-explanation is an issue. This assumption that people have that maybe the explanation is not good enough, that they have to over-explain, is quite common among IMGs. I've noticed it. So what you need to realize is that the explanation needs to be pitched at a level where it's very easy for the patient to understand. And usually, when you explain something in very concise fashion where it's simple, then you keep to time. Whereas when you tend to over explain, you almost make a mountain out of a mole. You overcomplicate it, right? So the key word is simplify, all right? And sometimes if you explain it in a really simple way, um, the patient will feel that they understand. And the way that you do that is by using the patient's own language, words, and build on their own reference. So it's like you're building a Lego set. You build it with their own building block, one on top of the other. These are common pitfalls in time management. The first one being not priming your case sufficiently. So you know the 3 minutes reading time? This is really vital for you to not just read the case, but to anticipate what might be coming up, what this case could be about, what problems, and how you're going to actually approach the case, especially if there's results, if there's significant information, you need to pick it up. So this will come with actual practice. And when you go back to review your consultation, you'll see, okay, I have all this question, but some of the information were already provided in the case briefing. Maybe I should not ask that next time, or I should phrase it differently. Or you could say, okay, next time when I see this case briefing, these are key information such as it could be a medication the patient is on, or their kidney function. So these are key information. Then the second problem is spending way too long in data gathering. And the problem with that is sometimes people are procrastinating clinical management because they have this fear of missing something. So they keep asking more questions. And this is a big problem. So you might think that you're going to get more marks by asking more questions and not missing something, but you're missing a big chunk of the mark in clinical management. And clinical management is weighed more heavily. So the examiners are not expecting that you're going to ask every question, every symptom. The question that you're going to ask, we're going to talk about that in a moment about what are the key questions and how to categorize them. Um, so irrelevant questions. Sometimes people ask irrelevant questions when they're anxious or they don't know what to do. They just ask more questions, and that's a problem. That's a big problem. Another one is number four is long pauses. Sometimes you don't have a good flow in your consultation. If you pause a long time, you're still reading the case briefing because you didn't do a good job at the beginning, or you're overthinking and you're second guessing yourself. So then there's that delay time, and that's dead time. Another problem is if you're disorganized. So, for example, you're asking more questions in clinical management about the history taking, and you're asking a lot of questions when you should be managing. So, you need to be really clear on the part of the consultation where you're at. Are you in data gathering or are you in clinical management so that you don't mix things? And last one, which Osai did mention, over explanation. And that's a big one. So the first thing to consult in 12 minutes is to learn how to prime your case, right? So the priming is not just reading the case like that, but it's actually thinking and from an examiner's perspective, asking yourself, what is this case about? What am I being tested here? Or what could it be? So let's go over an exercise and let's try and prime this case. So I'll give you 3 minutes so that you can prime it and write in the chat what are you thinking and what are you anticipating. And then we're going to look at this priming and key questions that you might want to ask as well. So take 3 minutes and actually do that exercise because this is part of the learning how to prime a case well so that you go in with an organized mind. You want to actually be priming the case in a way that works for your brain. What I mean by that is, so when you do the exam, you should be aware of yourself, as in, when you've been practicing cases, you need to know I tend to forget eyes or I tend to forget red flags. As you mentioned, Elisha, if you forgot red flags, then for the exam, you should be priming it in a way that you write it on your whiteboard as well if you need to. All right. So sometimes I've seen people, they write a lot of things on the whiteboard and it's not really smart. You need to be writing key points that you tend to forget or you know that would be useful for you. Don't just write things on the whiteboard, but be very smart as in knowing yourself as in what you do you tend to forget. Does that make sense so far? Okay. Now, if we're priming this case together, we can see that this is a 12-week-old mother, a baby who's actually presenting, had some problems with gastroesophageal reflux disease, and is also taking Gaviscon. All right. So we should be thinking about, so this looks like it is a case of a chai. So what are the possible cases you might get for a chai case? Could it be like a safeguarding concern? Could it be the reflux problem? Maybe the mom is asking for something more because the child is still having reflux. Or could it be now the child is having constipation after taking the Gaviscon? So you see how I'm anticipating the scenarios? Um, could it be the problem with um, cow's milk protein allergies? And then thinking about the red flags, which I can see Kong has already put some red flags, relevant red flags. Yeah. And thinking about the impact on the mom, and also considering the psychosocial with respect to support at home. So you see, it's very important that you already organize your thoughts before going to it. And you need to also remind yourself about the structure. So it's almost like you have a roadmap. That's what you really need so that you're not wasting time. So, for example, if you're going from London to Manchester, you're driving. If you don't put on the sat nav, you don't write down your destination, chances are you might take a longer route. You might miss something, or you might go on a different route and then come back. Whereas if you put the sat nav, then it will actually guide you. Does that make sense? So similarly, when you have a consultation framework, you will know where you are with respect to time and what's the next segment. So that's why it's so important that you're very familiar with this and know it without having to look at it, ideally, because you've been practicing so much, it's become second nature. You know that after I ask question about the story, I need to consider the patient's ideas, concern, expectation, and then I go into the biomedical and then the psychosocial. After doing that, I readdress the eyes. See, like this is the structure that I encourage trainees to use. Now, maybe some of you might have a different structure, all right? You could have a different structure as long as it works for you, okay? I will give you the reason why I suggest you actually go from story to eyes to biomedical to psychosocial in a moment. So you understand the logic. To take a very good history, you need to sharpen the axe. So what I mean by sharpening the axe is every time you ask a questions, it's almost like you're using this axe to cut. And the quality of your questions is going to determine how targeted your history is. For example, if your history is pertinent, if your questions are pertinent, they're going to cut through and you're going to find information earlier and you're not going to have to ask a lot of questions to get that information. So, for example, when you first start a consultation, in the first couple of minutes, it's really important to get the narrative. So the narrative means what's a story. Most trainees, they're obsessed about the medical. They tend to ask questions about the symptoms and they have to ask a lot of questions to get the story afterwards. Whereas if you ask question about the story, what I mean by that is asking questions such as, tell me the story in your own words. Can you take me back when you first noticed this problem? What's changed since it's began? How is this affecting day-to-day life? What have you tried so far? How did it go? So that typically the last one would be when it's a follow-up consultation. So you see, these questions are going to encourage the patient to tell you a bit more. And that's open question. You see, none of these are closed question. None of these are just a biomedical, the symptom. So in the first couple of minutes, be curious. Ask question about the story. That way, you give the patient the freedom to tell you what's on their mind, what's important. From there, then the next thing you can do is to elicit the patient's ideas, concern, expectation. Now, among you here, who usually do the eyes afterwards? So give me a one in the chat if you usually do the eyes after the story. And give me a two if you do it differently. Right. So some of you are doing it differently. All right. Um, Let me share with you the reason why we do the eyes within the 3 minutes mark, ideally. It's because eyes is a window to your patient's world. Think of eyes not like a checklist, but as a compass. And by asking eyes, what happens is that it guides your data gathering and helps you shape how you're going to ask your questions and be more focused. Then it's going also, when you readdress the eyes, to shape your explanation and anchors in a shared understanding. But without the eyes, what you'll tend to do is you're going to be treating the symptoms and you're not treating the whole person. So, for example, if I know a patient is thinking about thyroid problem because their sister has got thyroid problem, they're coming in with, let's say, tiredness, then I can target my question. I can ask more relevant question to consider thyroid problem when I do the biomedical. Whereas let's say if I didn't know the patient is thinking of thyroid, then at 6 minutes, the patient says that they're thinking whether it could be thyroid because of their sister. Then I need to go back in biomedical. Do you understand? And that's not good use of your time. Whereas if I already know, then I use a compass to guide the history. I will take less time. That will save you a lot of time. And that's what many trainees have said to me. If you're finding this video useful so far, drop a like so the algorithm knows that you want more videos like this. And if you want to get more teaching from me, I'm running a free live event on Saturday, 15th of November at 10 o'clock, where we're going to launch Consultation Blueprint. This is a book that has been built from hundreds of stories of GP trainees who struggle with the SCA and analyze what exactly separates the top scorers compared to those who fail and keep failing. And on Saturday, 15th of November, I'm going to reveal the full blueprint. So if you want to register your seat, it's completely free and you can unlock free bonuses. So click on the link down in the description and save your seat. I'll see you at the launch. Usually the eyes needs to be asked in context, okay? And don't just go through a checklist, idea, concern, expectation, but let's say they tell you thyroid, then pick up on the cue and ask them the next question. And for example, ask them, so how's your sister doing? And then ask them, I understand. So I'll consider thyroid as I assess you today. And then ask the next question. What's the biggest worry you might have right now? See, like it should be a conversation. All right. And expectation as well, you ask it in context. Then we come to the biomedical. So now we know what the patient is thinking. Then we can ask more relevant questions. And the biomedical, let's go over a scenario. So let's say you get a patient who's coming up with tiredness all the time. Tell me more about your tiredness. Ideally, you would have already asked that in the story. All right. But now we're getting into the more close question now. So we need to be thinking about the differential in our mind. So in data gathering, you get marked for considering various differentials. So thinking whether it could be stress, could be iron deficiency anemia, diabetes, post-viral, depression, could be sleep apnea or hypothyroidism. Then when we think about the red flags, thinking about unintentional weight loss, night sweat, fever, loss of appetite, lymphadenopathy, change in bowel habit, bleeding, or witness apnea. Now, this is not an exhaustive list, and there's a lot of other questions you could ask, but you need to actually be selective in the question you ask. So you need to be thinking of the patient's age, their gender, which one is most likely, and which one you can't miss. Okay? So in the exam, you don't have to ask all these questions to pass. You can think of two or three differentials, but it needs to be relevant. So you might think, let's say if it's a younger demographic patient, if you're thinking the patient might have like an infection, you could ask about fever. Or for example, in this case, let's say the patient was thinking about hypothyroidism, then you can ask about these key questions. Okay, so we've got the story, we've got the patient's eyes, the first bucket, we've got the biomedical, we've asked relevant red flags to make a safe assessment, second bucket. Now we're moving to the last bucket. So the third bucket is a PSU, psychosocial, situation, and occupation. Now, a common pitfall here is thinking PSO is about smoking and alcohol. So I've seen these trainees ask, do you smoke? And they think that once you've asked about this, then your PSO is done. But that's not the purpose of the PSO. Okay. So the purpose of PSO is to be thinking about the person in their life, in their work, how is it impacting them? Now, smoking may be part of it, okay, but it's more about having a uh, context and then situation about the whole environment the patient living in and the social life, whether they have any support. Um, so these are really important for you, how you think about the PSO. Okay. And then ideally, you want to ask a PSO in context. So, for example, if a patient is coming with tiredness, the way I'm going to ask it would be, has this tiredness stopped you from doing anything? Are you getting any help at home? Not like just who lives at home with you, which is sounding very scripted. So let me know if this makes sense so far. Are you finding it useful so far? Yeah. Thank you so much. Great. Any questions so far?
Hi, Dr.
Yes.
Erwin. Emmanuel here, New Zealand. Um,
Yeah, ask your
yes,
question. Yeah.
yeah, the structure is quite, it's excellent to know where, what should be where in the structure. But I was reading the blueprint,
Mm-hmm.
and I've come across the biomedical, and I kind of struggle what to include in the biomedical. Am I going, is that the opportunity to run through the past medical history, drugs, stuff like that.
So, very good question. So, the biomedical is everything that encompasses the medical issue. So, yes, drug history will come under biomedical, family history as well, the symptoms, the onset, the duration. So, all these are medical, okay? The red flags. However, what you need to realize is that you're taking a GP history, which means you don't want to take a hospital history where you're involving every sections of the biomedical history. Because if you do that, then chances are you're going too deep. And in your exam, you don't really need to go to that depth like a hospital history. Okay? You need to ask enough to have made a safe assessment and considered the relevant differentials. For example, to be able to say, okay, I can see that this patient is actually high risk or low risk or medium risk, and that will help you to know what's the next step to do. All right. So that's what the biomedical is. It's anything related to the medical problem, the history, um, and you need to be selective though. There are questions. So the way I categorize it is what's really vital. You can't afford to miss this question. And then there's question which is what's good to ask, and then what's nice to ask. Okay, so vital question, what's good to ask, and what's nice to ask. A lot of times, people who run out of time, they're asking a lot of nice questions, good question, but not so much of a vital question because they're missing like the key one, and they're asking question to think what's the next question, what's the next question, and that's not a good approach. What you need to do is knowing, for example, if a patient is coming in with tiredness, I've already asked about their mood. I don't need to ask more question about depression. Like it's going to be going too in depth. Let's say, for example, it sounds more like this patient is having tiredness because they're having problems with diabetes. So I'll target more question like related. Does that make sense?
Yeah. I was just thinking to myself, would it be more when you have the story out and then you go on to question under the biomedical, and then you follow up with the ICE by saying, okay, uh, having listened to you, what do you think might be going on after you've sort of gathered more? So, but I think you leave it open to people to place the things where they want.
What's really important about ICE is that it should not be forced.
Yeah.
If you feel like you're comfortable asking the ICE afterwards, and that comes naturally for you, you can do it that way. All right. But the mistake you don't want to make is asking ICE too late. Asking ICE is one thing, but more important is you have to readdress the ICE. If you don't readdress the ICE, it's like you've opened a door, but then you pass through it, but you haven't closed the door. Okay, so you need to complete that loop. Otherwise, there's something missing, and the patient will go home still thinking whether it could be thyroid. Should the doctor have given me some medication for my thyroid? Like, you need to complete that loop. You have to ace the ICE. What I mean by ace is acknowledge, collaborate, and empower the patient. Okay, so acknowledge the ICE. So, for example, saying to the patient, I know you thought this could be thyroid as your sister had similar problem. And then you can tell them if you think that's the case or not. So, for example, let's say we don't think that's the case. Maybe we think that the problem is due to, let's say, the patient is not sleeping well. Then we can say to the patient that I've asked you a few questions to consider thyroid, but it doesn't sound like you've got a problem with your thyroid because when I asked you X, Y, or Z, you didn't have any of these. But you've told me that you've been quite stressed lately, you haven't been sleeping well, and you've been drinking alcohol to help you relax. So it looks to me that the lack of sleep and the problem with the work stress has contributed to this tiredness. See how I'm actually readdressing the ICE right now? So it's more of a collaborative way of doing it in terms of involving the patient in my thought process and then empower the patient thinking about, for example, let's say the patient thought that maybe he had to do some blood tests. It could be reasonable to do some blood tests in that instance. So you could say, yeah, I know you were hoping for some blood tests. We could run some blood tests as it will help us exclude any other problems. Um, and if we do find anything, we can correct. For example, if there's any issues in your blood count. But if it turns out to be normal, then there are things that I would suggest in terms of lifestyle, if you'd like. So empowering the patient and then asking them, would that be something that you'd like to consider? So do you see how this is being done in terms of readdressing eyes? We're achieving shared understanding because a patient thought they had thyroid, but we think it's not thyroid, it's more lifestyle stress. So we meet them where they're at, and then we bring them down where we are. Whereas if I didn't do that, I would just saying the patient, yeah, we'll do some blood tests and then we'll take it from there. The patient doesn't know what's going on. Some of you have mentioned is that you struggle with negotiation. For example, a patient has come in with something like a demand. How do you address that? So is this something that some of you are struggling right now? Negotiation. Yeah. Okay. So the first thing is when you approach negotiation, let's say you know a patient is asking you something you can't prescribe. You should not look at it as a confrontation. You should approach it as a collaboration. Okay. So you need to be thinking, why is this patient asking for a scan of their back, or what are they asking for tramadol or benzodiazepine? There's usually a reason behind the reason they're asking it. Could be that they are not sleeping, so they are feeling desperate, or it could be that one of the relatives just had cancer, so they're worried about cancer. So we need to find out a little bit more. And then think of it as a team effort instead of you versus the patient. If you found this video useful, don't forget to sign up to Consultation Blueprint Live, where I'm going to show you the exact blueprint that hundreds of GP trainees have used to pass SCA with confidence. I'll leave a link down in the description, and I hope to see you there.